Hello, Dr. Roger Henderson here, and I'm one of the co-hosts of the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, we'll be discussing transient ischemic attacks, or TIAs, and this topic's been requested by one of our regular podcast listeners, so many thanks for this great suggestion. The age-adjusted annual incidence rate for TIA in the UK has been estimated at around 190 cases per 100,000 of the population. But there is a big caveat here. The exact number of TIAs is difficult to establish with certainty due to the potential for a transient neurological deficit to be caused by the many conditions that mimic true cerebral ischemia. And also because a large number of TIAs go unrecognized, with approximately half never coming to our medical attention. Now, often described as a mini stroke, TIAs are not minor events. They are urgent warnings, and how we respond in those first hours can significantly alter a patient's future. So let's begin by reframing what a TIA actually is. Now, traditionally, TIAs were defined by time. So, if neurological symptoms resolved within 24 hours, that episode was labelled as a TIA. But that definition has evolved, and it's more usual now to use a tissue-based definition. So, a TIA is best thought of now as a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction or permanent tissue injury. Now, this shift matters because it aligns the diagnosis with the underlying biology rather than us setting arbitrary time limits. Now, as we all know, in practice, most TIAs last far less than an hour, and many resolve within minutes, and that brevity can be deceptive. Patients often feel absolutely fine by the time they see us, and so we might be tempted to lower our clinical guard. But this is exactly the moment where our vigilance is most critical, since the risk of a full ischemic stroke is highest in the first 48 hours following a TIA. In fact, a significant proportion of patients who go on to have a stroke report having had TIA symptoms shortly beforehand. And so, until the neurological symptoms and signs have resolved completely, you cannot assume the event is a TIA, and so you should proceed with your investigations and management as you would for a working diagnosis of stroke. So, what's happening physiologically here? Well, at its core, a TIA is caused by a temporary interruption of blood flow to a specific vascular territory, and so the mechanisms mirror those of an ischemic stroke. Large artery atherosclerosis can lead to either reduced flow distal to a stenosis or embolization from an unstable plaque, whereas small vessel disease, often driven by chronic hypertension and diabetes, affects the penetrating arteries and leads to lacuna-type events. Cardioembolic sources are another major category here, especially in patients with atrial fibrillation, where thrombi formed in the atria can dislodge and travel to cerebral vessels. And there are also cases where no clear source is identified, and these are known as cryptogenic TIAs, and increasingly are being grouped under the concept of embolic stroke of undetermined source, or ESUS. And then there are the less common causes such as arterial dissection or hypercoagulable states, which should be considered in the appropriate clinical context, particularly in younger patients or in those without traditional risk factors. Now, speaking of risk factors, I have no doubt this list will be familiar to most of you. hypertension stands out as the most significant, both at the individual and population level. And diabetes, smoking, obesity, a sedentary lifestyle, poor diet, and excessive alcohol use all contribute here. Now, age is, of course, non-modifiable, but it remains a strong predictor, and a prior history of TIA or stroke dramatically increases the likelihood of recurrence. Now, let's talk about presentation, and one of my golden rules here is to suspect a TIA in any patient with sudden onset focal neurological deficit that cannot be explained by another condition such as hypoglycemia. And the hallmark of a TIA is that sudden onset. Symptoms are typically focal and correspond to a specific vascular territory. And so you can use this to try and ascertain the arterial territory involved. So for anterior circulation ischemia in the territory of the carotid, there's usually dysphasia, typically indicating left-sided cerebral hemisphere ischemia, and the transient monocular visual loss of amaurosis fugax. With posterior circulation ischemia in the vertebrobasilar territory, we see isolated homonymous hemianopia, diplopia, vertigo, although not usually in isolation, and bilateral limb weakness. Now, one of the challenges in our clinical practice is differentiating a TIA from its mimics, as conditions such as migraines with aura, seizures, syncope, and even metabolic disturbances can all produce transient neurological symptoms. But the key distinction often lies in the pattern and onset. TIAs are abrupt, focal, and negative in nature, meaning a loss of function rather than positive phenomena such as flashing lights or tingling that spreads. Now, if possible, always ask family members or other witnesses about the patient's symptoms, as their fleeting symptoms may be more obvious to an observer than to them. And a practical tip worth remembering here is that confusion, syncope, lightheadedness, and altered levels of consciousness are not usually associated with a TIA. Now, as we know, by the time we evaluate our patient, their symptoms may have completely resolved, and so that makes the history absolutely critical. We need to carefully document the onset, duration, progression, and the nature of the patient's symptoms, and associated features and risk factors should all be explored in detail. A history of previous atrial fibrillation or a recent MI may point towards a cardioembolic source. Visual field deficits or language disturbances suggest cortical involvement, whereas pure motor or sensory deficits may indicate a lacuna process. Our physical examination, even if the patient is feeling well, should never be cursory, even if the patient appears neurologically intact, as we still may find subtle findings. I would suggest we use a validated tool such as the FAST or Face, Arm, Speech test to screen people with sudden onset of neurological symptoms for a diagnosis of TIA or stroke. So, remembering this, we score 1 point for each of these features. Face weakness for F, arm or leg weakness for A, and speech disturbance for S. And we should suspect a TIA or a stroke if the score is 1 or more. A thorough cranial nerve examination, motor and sensory assessment, and evaluation of the patient coordination and reflexes are also essential. Cardiovascular examination, including checking for carotid bruits, can provide important clues, and fundoscopic examination may reveal evidence of chronic vascular disease or even embolic plaques. Now, once you suspect a TIA, evaluate the patient urgently, as the goal is not only to confirm your diagnosis, but also to identify the underlying cause and to stratify the risk for that patient. And neuroimaging should ideally be performed within 24 hours. An MRI with diffusion-weighted imaging is the preferred modality here because of its sensitivity in detecting small infarcts. But if MRI isn't available, then a CT scan, preferably with angiography, should be obtained. Equally important is the assessment of the cerebral vasculature, and carotid ultrasound, CT angiography, or MR angiography can all identify significant stenosis or other vascular abnormalities here. Cardiac evaluation is critical, so do an ECG to look for arrhythmias, particularly atrial fibrillation. Echocardiography can help identify structural sources of emboli, such as valvular disease or intracardiac thrombi, and in some cases, prolonged cardiac monitoring might be necessary to detect intermittent arrhythmias. Lab tests should include a complete blood count, metabolic panel, coagulation studies, lipid profile, and blood glucose, because these tests not only help identify contributing factors, but also help to guide management of our patient. But the primary objective of management is straightforward: to prevent a subsequent stroke. But achieving that needs a multifaceted approach. And as I've said, time is absolutely of the essence. Studies have shown that early, aggressive intervention can reduce the risk of a stroke by up to 80%, but the risk of recurrent stroke is up to 10% in the first 7 days following a TIA. Now, antiplatelet therapy is a cornerstone of treatment here. So give a loading dose of aspirin immediately to a patient with a suspected TIA, unless contraindicated, and give a proton pump inhibitor to anyone with dyspepsia associated with aspirin use. In patients who are allergic or intolerant to aspirin, then clopidogrel is the alternative, and refer the patient immediately for specialist assessment and investigation to a TIA clinic or a suitable alternative within 24 hours of onset of symptoms. Start dual antiplatelet therapy with either aspirin and clopidogrel for 21 days, or aspirin and ticagrelor for 30 days in patients presenting within 24 hours of a TIA and who have a low risk of bleeding. And after completion of dual antiplatelet treatment, or a clopidogrel loading dose where dual treatment is inappropriate, for long-term prevention of vascular events in people with TIA without atrial fibrillation, single antiplatelet treatment should be used, with clopidogrel recommended as standard treatment, but aspirin should be used for anyone unable to tolerate clopidogrel. Now, give an anticoagulant with a rapid onset of action to patients with paroxysmal, persistent, or permanent atrial fibrillation or flutter as soon as intracranial bleeding or other contraindications have been excluded. Start a high-intensity statin immediately, unless contraindicated, in all patients independent of baseline LDL for long-term secondary prevention, and consider increasing the statin intensity or dose if the patient is not currently taking a high-intensity statin at the maximum tolerated dose, and use an alternative statin at that maximum tolerated dose if high-intensity statin therapy is either unsuitable or not tolerated. Now, as you know, blood pressure control is absolutely critical, so any antihypertensive therapy should be optimized, and for patients with diabetes, strict glycemic control must be addressed, as well as lifestyle modification. Patients should be counseled on smoking cessation, adopting a heart-healthy diet, engaging in regular physical activity, and limiting their alcohol intake, as these interventions, while sometimes overlooked, can have a profound impact on long-term outcomes here. The management must also be tailored to the underlying etiology. So, in cases of significant carotid artery stenosis, for example, revascularization procedures such as carotid endarterectomy may be considered, particularly when the degree of narrowing exceeds 70%, although this decision does become more nuanced in moderate stenosis, where the risks and benefits must be carefully weighed. Now, the risk of stroke following TIA is, as we've said, considerable, potentially due to unstable plaque, thrombus, or exposed thrombogenic surfaces. And the probability of a second stroke is heavily weighted towards the increased risk in the early post-TIA period, with half of the 10% of stroke events which occur in the 3 months following an initial TIA occurring in the first 2 days. The cardiovascular complication rates following a TIA are approximately half the rate of those of completed stroke, with the rate of complications in the first 3 months after a TIA being of the order of 3%. But a 2019 meta-analysis reported a 1.2% risk of stroke at 2 days and 7.4% risk of stroke at 90 days after a TIA. As a result, despite complete resolution of symptoms from a TIA, disability and institutionalization are not uncommon, unfortunately, and the 5-year risk of institutionalization after a TIA is 11%. So we mustn't view TIA as an isolated event. It's a signal, a brief interruption that reveals an underlying vulnerability in the cerebrovascular system, and it offers us a narrow but crucial window of opportunity. And if we act decisively during that window, we can prevent devastating outcomes. So for us as GPs, the takeaway is clear, I think. Recognize the symptoms, take every TIA seriously, regardless of how quickly it resolves, act systematically, investigate thoroughly, treat aggressively, and always think about prevention, not just of the next TIA, but of the next potentially devastating stroke. So that's a brief overview of TIAs, and I do hope you found it helpful. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts, as in this case. We really do like hearing from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups that occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.